it's not on the slides about depression, is that a lot of times it doesn't look like depression, like we're seeing at the jail. A lot of the kids at the jail are irritable and they're acting out. So that can definitely be a sign of depression. So sometimes we label kids bad kids when actually they may just be depressed. Does that make sense? There we go. Apparently very, very prevalent, very recurrent. This one. The prevalent, the recurrent, their high rates of comorbidity, anxiety, ADHD, substance abuse, cognitive disorders, poor psychosocial outcomes. I guess also why I see a decent amount of these folks at the jail. High risk for suicide. I mean, it's been a terrible year for that since COVID. We've seen so much. I mean, I know if you're new here, you make it small, but it was probably twice as much this past year as we have seen in a while. There's also high risk for substance abuse, and I think we had about twice the substance abuse that we've seen this year too. I know the inpatient unit's been full of cannabis. I think we had a lot of cannabis hyperemesis, things like that going on this year as well. So part of difficulties with children and adolescents is problems with diagnosis, developmental variations, complex factors in the clinical course, and kind of specifying the treatment. So prevalence for children is 2%, fairly rare. Adolescents, 4 to 8%. The male to female ratio is 1 to 1 in childhood, and in adolescents is double for females. Cumulative incidence by age 18 is about 20%, which is a large percent of our population. And each generation has gotten higher risk for major depressive disorder. I can't wait to see all the data that comes out after COVID. How ridiculous it is. I know I've seen the data on the anxiety, and that's, I think, increased like 20-something% anxiety. It went from like 40 to something like 60% or something ridiculous.
I don't think I've ever seen you without a mask, and it's very discombobulating.
I keep getting that. I hope that means I'm not heinous looking. I feel like if I was that heinous looking, nobody would say anything. But
I would recognize you with your mask, but I recognize you by your voice.
If I hurt your appetite, I apologize. I put a mask back on. Dysthymia. Dysthymia is fairly common. Again, this increases again around adolescence. I was just, who was I with when I was looking at the suicide data? I don't think you're here, but we're looking at the suicide risk data. And suicide is one of the most common causes of death for most populations. It is the most common cause of death for most populations aged 15 to 19. And then some of the up to 24-year-old demographics, and a lot of that has to do with depression. So that just tells you how serious this is. And again, unfortunately, you'll ever go on the CDC website and see all the they have so much data. You can just check like any cause of death or anything like that at different ages. Complexities. There's overlap of mood disorders, other mood disorder symptoms. There's symptoms that overlap with other comorbid disorders. I think they call the anxiety and depression like the ugly twins. They tend to have a lot of overlap. Nice thing about that is the same medications work for both conditions, which is nice. Again, there are other, for y'all especially, like medical conditions that can contribute to that. I think, we have a lot of folks that come in that have like adult problems. The medical conditions are adult problems, and kids don't have the coping skills to necessarily deal with those adult problems. I think that contributes to a lot of what we got going on. I think, if I told you, sometimes my motto on consults is let's address the stress and see what's left over. Unfortunately, compliance isn't all that great. So the major depressive disorder criteria, the DSM-5, there's 2 weeks of pervasive change in mood manifested by depressed mood, which makes sense. Loss of interest and pleasure, and irritability. And the reason I highlighted irritability is because that's not the criteria in adults, but that's the criteria in kids. And I think you rotated with me at least one point. I said something. I don't know what magically happens when we turn 18. We're not grumpy anymore when we're feeling depressed. But like I say all the time, these are made up diagnoses. So if you don't have anhedonia, irritability, depressed mood, you cannot meet criteria for major depressive disorder. Other symptoms that you have to have 5 or more symptoms to include appetite concerns, either overeating or undereating. We overeat carbs when we're depressed because so serotonin is based on tryptophan, which is a protein. Eating more protein doesn't get it across the blood-brain barrier. Insulin does. So when we're depressed, we crave carbs to trigger the insulin to help the proteins cross the blood-brain barrier. That's why we like our crunchy carbs, our potato chips, our Little Debbie's, our Starbucks that's just coffee that has 500 calories, that kind of stuff. Other things we see a good bit problem is weight changes, either weight loss or weight increase. Sleep can be all over the place. You can decrease interest. Concentration is a big one. We have a lot of folks that show up with concentration problems, with depression, anxiety. The way I like to conceptualize that is, especially with epic one, right? You ever like the computer just slows down, you're trying to type your note, and then you notice that everything you just typed types maybe like a few seconds after you just did it, and then you made a mistake, so you have to hit backspace, and then it goes too far because this computer slowed down, and then you go to the taskbar and something else is eating up 80% or 90% of the CPU. That's the same way our brain works. So if our brain is overwhelmed with a task of depression or anxiety, it doesn't leave much left for concentration or our coping skills, to be honest. So it's kind of the same type of phenomenon. Symptoms represent change prior to functioning and produce impairment. That's basically one of the main criteria in all psychiatric diagnosis. There has to be some kind of functional impairment in social, academic, professional kind of environment. And they're not attributable to something like substance abuse, other psychiatric illness, medical illness, medications, things like that. So this is the pattern of depression. So basically you go from normalcy to where you're feeling depressed. And then response to medication actually added here is always a couple weeks behind. Remeron's the fastest, starts kicking in around 3 weeks. Most of the medicines don't start kicking in until about 4 weeks out. So that's kind of like where we are right here. And then we get remission. And then we tend to have a lot of folks that say, oh, I feel better, I don't need this anymore. Just sometimes folks will stop taking the medications, they may have relapses. So if you look at this, there's a question of, how long should somebody be on a medication? And a lot of times the data says a year or more. One of I feel like I'm a used car salesman when I try to talk to people about medications, but one of the things I talk about is whatever our brains do, whatever our bodies do, we get better at, right? The more we run, the better we get at running, the more weights we lift, the stronger we get. The more we feel depressed, the better our brain gets at feeling depressed, with neuropruning, things like that. So with neuropruning, we're getting rid of the stuff we're not using. So if you're using your depression, your pathways a lot, you're really kind of setting yourself up for a little bit more depression down the road. So that's why addressing these concerns can be pretty helpful. I did not do a good job of putting this in here, but this is from Stahl. And this is why we get the black box warning, essentially. What this slide is showing is when we're depressed, I guess we're the frowning face with the cloud over us, we increase our receptors for serotonin. We're like, give me neurotransmitters. We need more neurotransmitters. Well, actually, once the neurotransmitters come, you see we don't have very many neurotransmitters. Once our receptors actually see the neurotransmitters coming, we actually start downregulating before we feel better. See that? And that's where that kind of the X is, and that's where we're most likely to have new and alarming suicidal thinking. And that's part of where the black box warning comes from, and that's why they want you to, guidelines say, check in on them like every week when you first start taking medications. But who has time for that, to be honest? We should, right? We should also have time for that. But in practicality, how often does that happen? So that's why it's really important to talk about the black box warning and make sure everybody's on the same page with the concerns for the black box warning that parents are watching the kids. That said, though, I can't say I've ever had a clear-cut case of suicidality from starting a SSRI or antidepressant. And this is a 100-page slide, so I told Whitney that I'll send it to y'all if you want. you want to read the really long history of the black box warning, you're welcome to. It's kind of boring. I'll save y'all from that. But anyway, that's kind of where this comes from. So other things, so children, they tend to have more symptoms of anxiety, phobia, separation anxiety. They tend to get more clingy when they're not feeling good. They tend to have more somatic complaints. I know y'all never get that. You know, anybody coming in with stomach upset that doesn't seem to get better, or his headaches, or things like that. Kids get really irritable. Then temper tantrums increase, or sometimes kids get blamed for just have bad behavior, but a lot of times it's because they're not feeling good. They tend to have fewer delusions, and they have fewer serious suicide attempts. One weird thing about this age group is sometimes there's this fantasy of reunification. You know, familiar with that? Where they feel like they can meet mommy in heaven or something like that if they put themselves in that can happen. Or they don't even understand suicide to the point where it's like a video game and they'll just respawn. So this is kind of interesting how kids look at it. Adolescents are a little bit different. Adolescents tend to have more sleep and appetite disturbances, delusions. It's kind of like people are talking about me in the hallway. You know, somebody's, you know, I'm walking in the hallway, somebody's looking at it, and they look at me and don't say anything, and they're thinking bad thoughts of me, or they look at me and they think I'm fat or something like that, or they don't like the way I'm dressed. We tend to have more intrusive thoughts, kind of like that. What else? They tend to have more suicidal ideation. We see a ton of that. Attempts, cutting behavior, impairment of functioning. This is usually like, again, in those domains, social, academic, work. So again, their grades can be declining, losing friends, things like that. Compared to adults, the adolescents have more behavior problems and fewer neurovegetative symptoms, basically because they tend to have a little bit more energy than older folks. Dysthymia is in the DSM-5, and it's depressed mood or irritability on most days, for most of the day, for at least one year in children. For adults, it's 2 years. Again, you have to have at least 2 other symptoms, so it's not all 5 symptoms. So it can just be appetite, sleep, self-esteem, concentration, decision-making, energy, things like that. And basically you can't go for more than 2 months without having problems with it. And that 2 months, I think, is usually when I see this with kids, like EMDD, there's like a 2 to 3 month time period where you shouldn't have agitation or anger. I think that has to do with school, because they can kind of give you like, you know, if you're doing okay in school or during the summer, you're not angry or depressed during the summer, then usually there's some kind of other stressor going on. School is extremely stressful for kids. What else? Other things, not including the DSM, that can affect the feeling of being unloved, anger, self-deprecation, somatic complaints, anxiety, and disobedience can all be symptoms of dysthymia. Variant psychotic depression. This is where I hear voices telling me I'm bad and I should kill myself. Bipolar depression. This is where they have, right now is actually the peak time for bipolar depression. Right when spring starts, because the time change, the change in light as well. You're more likely to have a manic episode. But in kids, bipolar disorder tends to present first as depression. So the first episode would be a depressed episode, and then it will lead to like a manic episode down the road. I expect, unfortunately, we'll probably get some of these coming up in the next couple of weeks. Atypical depression. This is where we just we actually don't need. That's why Remeron tends to be like a really nice one for atypical depression. Seasonal affective disorder. I don't like winter. Like one of my bosses told me I was Olaf. Like he's like, you know, apparently he could see if there was a play in our department, I would be Olaf talking about how I love summer. I couldn't tolerate, good Lord, I could not tolerate Minnesota. Minnesota would be awful for me.
Big problem up north.
Yeah, man, I saw snow for 2 days this year. That was enough for me. Subclinical and subsyndromal depression. Again, that's usually like a time constraint and not have symptoms. Treatment-resistant depression. We have a decent amount of this, and everybody seems to forget about PMDD, but PMDD is real. Definitely PMDD, premenstrual disorder. You know, I was reading an article the other day about how birth control has significantly contributed to suicidal ideations in girls aged 15 and 19. And it was suggested because of just like the hormonal instability at this age, but such that just didn't tolerate the birth control. This is kind of new data too. I don't know if y'all heard anything about this. Yeah, and there was, it's not a problem over 24, but in that 15 to 19-year-old age group, the article is showing that it is a significant risk factor for suicidal ideations, much like the antidepressants. So
Was there like one form that was more
yes,
like worse than another?
yes, they rank them all. They did, like the closer you are to one, the more likely it is.
Yeah.
The article did rank them all like that. And I think it was the oral contraceptives that was most likely. I can find that article. It's on board tactic. I'm trying to read everything. I have a 13-year-old girl, so I'm trying to read everything related to that. And I'm also trying to read everything related to transgender stuff, because I'm trying to wrap my head around that. It's just been such a big risk factor for suicidality lately. I mean, I think it's been really big. That and internet, social media stuff. I'm trying to read up on that a little bit more, so I can help everybody out a little bit better with that. So psychotic depression. What else? Major depressive associated with mood congruent and incongruent hallucinations. I think I told you that. Usually, again, it's like I'm hearing voices telling me I'm bad, hearing voices telling me I should hurt myself, or hearing voices that paranoia, thinking people are talking about you, saying negative things about you. So that would be kind of congruent. Up to 30% of those with major depressive disorder. And then you got people self-medicating with cannabis, which probably contributes to some of this as well, especially since cigarette smoke and pressure is 20 to 30% doing dabs or wax, which is 80%. Now it is associated with more severe depression, which kind of makes sense if it's kind of pushed to the point where acting a little psychotic. Greater long-term morbidity, resistance to antidepressant monotherapy, which to me probably implies you need higher doses. I think, we've talked about before, you got things like Abilify that's an adjunct for depression that I've never regretted starting Abilify on somebody if I've kind of optimized the antidepressant before. And there's some new data out too, that stimulants mitigate the metabolic risks for atypical antipsychotics. And actually we use stimulants also for, other things that we use stimulants for is mopey depression. So say if you're like something like Zoloft, but you're still kind of mopey, got it at therapeutic dose for long enough, adding a stimulant can actually be really helpful, like something like a Vyvanse for mopey depression, especially concentration issue. And then I've got a lot of kids like in my autism clinic that have anxiety, that have aggression. Every single one of those kids that I have on a stimulant has not had any weight or metabolic issues when you have the stimulant along with the atypical. And the other thing, atypicals tend to block dopamine, stimulants add dopamine, but they actually have a synergistic effect for behavior. So it's really kind of neat. Let's see what else is going on. Stimulants are bad for people who have bipolar disorder, so be careful about that. And if they're, if you feel like it's more of a psychotic disorder, you gotta be cautious with stimulants. Let's see what else. Bipolar depression, again, it typically presents as unipolar depression the first go around. There's really, no way to really kind of, unless there's a strong family history of bipolar disorder, it's really kind of difficult. So yeah, we might have some folks that might start on like Prozac and then they get a little hypomanic. That's just something to be cautious for. There's really not much we can do. Again, unless there's a strong family history. Adolescents tend to have mixed episodes, increased suicide risk, just related to, again, having mixed symptoms of mania and depression at the same time. And again, that's just because, the brain's not fully developed until about 25. So a lot of our coping strategies are the frontal lobe, are able to kind of talk back to the amygdala, which is our kind of primal emotional part of our brain, tell it to calm down. Let's see what else. Atypical depression usually onset in adolescence, means they're more mopey, they have more appetite and weight issues, reactivity rejection, sleeping more, carb craving, we just kind of talked about that. Seasonal affective, usually onset in adolescents who live in regions with distinct seasons. I am so glad we just have 3.1. Symptoms similar to those of atypical depression, but are episodic, does not include Reactivity to rejection should be differentiated from depression precipitated by school stress. It's overlaps with the school calendar. And there's been some data about, y'all have seen stuff about vitamin D, right? Like kids that just aren't getting out, getting enough sun, things like that. It's not necessarily causative, but it's correlative. So again, we're not meant to be cooped up inside. So that's part of one of the issues we had this year was we were cooped up inside too much. That said, that wear your sunscreen. My wife got melanoma this past November. Don't get a tan next year. So, I'm all right. She's fine by the way. Clinical variants, treatment-resistant depression. It's a nuclear definition of treatment-resistant depression in children. Basically, this means that you've probably already tried at the first line. Where treatment resistant is defined as patients who had at least 2 trials of 2 different classes of antidepressants administered at similar doses for at least 6 weeks. Basically, at a typical dose. So basically, we'll talk about the TADS trial, but 36 weeks was the mile mark when everybody was doing pretty good. So actually, these things don't work just like that. So again, it should be for an adequate amount of time at an adequate dose. Complexities of comorbidity, recognition, diagnosis of depression, types and efficacy of treatment, psychosocial outcomes. Comorbidity is in about 49% of youth with major depressive disorder. Again, a lot of that's anxiety. What else? Dysthymia is something you often see. Anxiety disorders, 30 to 80%, which again kind of makes sense, but it's also nice that the same medications. Disruptive disorders, we kind of talked about that. We get angry, we get irritable. We tend to not listen. We aren't feeling our best. Substance abuse issues, again, sometimes we're self-medicating. It's escapism. We don't want to feel this way. We don't feel different. Major depressive onset after comorbid disorders, except for substance abuse. Cognitive problems, again, a complication. And we kind of talked about that because you're not feeling your best. You're more likely to not listen. You're irritable. What else? Differential diagnosis, we kind of talked about how anxiety, there's overlap. Learning, we talked about that because the concentration issues. Basically what happens when we get really depressed, we talked about the processing, but really the way it's working is the amygdala just stops listening to the frontal lobe. There are actually interconnections between the frontal lobe and the amygdala. And it really almost kind of shuts off a little bit. Where the amygdala just kind of does its own thing. The frontal lobe, which is usually considered the brakes for our behavior, it just isn't really able to tell the amygdala to calm down anymore because it gets kind of overwhelmed.
And that connection is like, are you saying that connection can be like severed if you have like severe depression?
Yeah, I mean, when you have severe depression, you can't concentrate at all. And then, if you think about it, when we're depressed, we tend to, if you look at our folks who are depressed, they tend to sometimes make some bad choices. Finally, part of planning and decision making.
And then when that happens, like, is there a way that would that be like more of a permanent thing?
Yes. Addressing the depression. Actually, so the MAOI system is actually based on the way the frontal lobe does kind of control the amygdala. So that's where the MAOI pathway comes from. So that's but there's medications too. And actually, therapy can actually make some neuroanatomical changes as well that you can actually see. So that's why therapy and medication is combined is what's best. I can talk about this a bit. Yeah, one of the things too, feeling overwhelmed. I don't know if I talk about it, but usually I talk about cumulative stressors. Usually things just keep adding up until you get to this point where something major happens. So if you keep getting bumped up with a stressor, something little is like losing your phone. That's been the big one. I lost my phone. Now, typically if you're doing pretty good, lose my phone, okay, I'll just deal with it. But if you're kind of hanging out here all the time, I lost my phone because it's always making good decisions because my frontal lobe is not being able to work like it used to because it's boom, you're into an episode where something bad happens, either self-harm behavior or suicide, or you've had kids like want attention to their phones, sending pictures, conversion stuff, all kinds of things like that. So cumulative stressors matter. So that's again, this is where something bad happens because of our mood. We're hanging out here all the time. Let's address that stress and see what's that. Usually that's against medication and therapy. It's a hard sell sometimes for medication, and that's why we'll talk about the TADS trial. Because I like having evidence. I'm like, this is why we do this. Then it sounds smart. And I feel like you listen to me. Again, differential diagnosis, anxiety disorder, separation anxiety, generalized anxiety disorder. A lot of this is overlap. I think you've seen some of that. It's very rarely do I have someone that just has like straight up depression, but they have some kind of insomnia and at least some kind of unspecified anxiety or something like that going on. We talked about learning disorders. Eating disorders is important too. Personality disorders, we see these, we can't ignore them. I know magically we can't have a personality disorder in 2018 because again, something magical happened to all of us when we turn 18, we're just totally different people. But personality disorders can often emerge pretty early on. That's something to be careful about. Adjustment disorders. Again, this is just mood and change and impairment within 3 months of a stressor. Don't meet full criteria for major depressive disorder. I'd say we probably see a lot of this when somebody gets bad news. I think we had a kid that had some bad news with y'all have all seen the x-rays of the kids that didn't poop last summer. Yeah, and then they all had to get colostomy bags, and I got called because they won't go with the colostomy bags, they get cleaned out. So that was an example of adjustment disorder. Or just any bad news, like new onset diabetes or something like that. Again, consider other disorders that last more than 6 months, like dysthymia or something like that. So general medical conditions can be accompanied by symptoms of depression. They tend to impact the course of depression. Depression makes medical problems worse, and medical problems makes depression worse, and they all make sleep worse, so they actually kind of interact with each other. I think you've seen the pain. You know, sometimes we get consults from the kids who report a 10 out of 10 pain, and they're like this. And the positive hand behind that head sign. So yeah, so again, if we're depressed, we're going to report more symptoms of pain and things like that. And sometimes people have just difficulty differentiating between emotional pain and physical pain. Major depressive disorder can be diagnosed if depressive symptoms precede and are not solely due to medical illness or medications to treat medical illness. Major depressive disorder is higher in certain medical illnesses. Chronic illnesses often affect sleep, appetite, energy, and pain, which makes our moods worse. Guilt, worthlessness, anhedonia, hopelessness, suicidality are usually not something you see in medical illness. So you shouldn't feel guilty because you're illness. You shouldn't feel worthless because you're illness. You shouldn't not be able to enjoy things anymore. That's so that I'm like, if usually the way I word it is, if you could do this, would you want to? You know. Hopelessness and thoughts of wanting to die are not something you typically see with medical illness. Other thing that's kind of interesting, isn't it? I know it's not something you'll see, but you know, the conduct disorder is a risk factor, or chronic medical illness is a risk factor for conduct disorder. Like you ever see like our kids with CF, they're like doing bad stuff.
Happens a lot with the cancer kids.
Yeah, the cancer kids. And then I had one kid with the sickle cell that was like attacking the nurses with a remote control car. I got called about that. Did you hear about that?
Parents are scared to discipline the child, so they don't have a lot of structure. At least that's what we have.
Yeah, so what happens is people feel sorry for the kids, so they don't set limits. They kind of get away with everything. So that's kind of interesting. And I think, you know, depression probably, you know, kind of goes hand in hand with that a little bit too. Again, you know, medical conditions often see depressive symptoms or things like cancer, which makes sense. Hypothyroidism, which makes sense. Lupus, acquired immune deficiency, anemia, diabetes, epilepsy, CF, chronic fatigue syndrome, things like that. I thought I had that after mono. I didn't like mono. Medication-induced symptoms. It was bad. Apparently, the older you get when you get mono, the worse it is. Yeah, like I had 104 temperature when I was interviewing at MUSC. Yeah, it was, and all they wanted to talk about was like, how has your illness impacted your view on going to medicine? And that was like all the questions I got. I didn't even Dr. Stallworth here. I got it right. He's an awesome guy. Other medication-induced symptoms. Stimulants. This is counterintuitive, but the dose is too high. It actually can make you depressed. that sometimes they hear zombie, but also if the dose is too high, it can make you depressed. Neuroleptics.
How does that work?
You ever hear about, parents saying the kids get slowed down too much, or the kids are like zombies?
Okay. I mean, I haven't had one of those yet, but like,
Yeah.
like what's the mechanism?
So basically the way they work is, that they stimulate the frontal lobe and the motor cortices. So basically by stimulating that too much, it can slow you down too much. So they get slowed down. I know it speeds up the sympathetic peripheral system, but in the brain, it can actually slow things down to the point where you're mopey. That's about the best I can explain right now off the top of my head. What else? We just talked about the contraceptives, corticosteroids. That makes sense too. So I had to take steroids when I had mono, and boy, I felt better. But I don't know if I felt like if it was like this is my normal baseline. I felt this bad, and I just moved back up here, or if I went past this. I didn't do anything strange, so I think I just moved back down, moved back there. But yeah, I noticed a difference with that. 30 is the magic number of like prednisone, 30 milligrams. Over that's the one that's most likely to push you into some kind of like, which most kids wind up getting actually, but that's the magic number. To having like a type of bereavement. I mean, it makes sense, bereavement. So it's worthwhile asking about loss, especially now when there's been so much loss. It can be made if the child has moderate, severe functional impairment, psychosis, suicidal ideation, or acts prolonged course following bereavement, predisposition to major depressive disorder may be related prior to major depressive disorder family history. And I think if you have bereavement, it also predisposes to having depression down the road. Again, whatever we do, we get better at. So that kind of lays down some of those tracks. So median duration in youth is about 7 to 9 months. Community is about 1 to 2 months. Predictor of longer duration, so it's the severity, comorbidity, negative life events, parental psychiatric disorders, poor psychosocial functioning. Remission is a period of 2 weeks to 2 months with one clinically significant symptom. 90% of major depressive episodes remit 1 to 2 years after onset. And 6 to 10% are protracted. What else? Relapse is an episode of major depressive disorder during remission. I think I should do that chart. So that's what I'm referring to. Predictors of relapse, natural course of major depressive disorder. It actually does kind of come and go. Same thing with ADHD. They found out recently that ADHD is actually more cyclic than chronic, which is kind of interesting. That's some of the new adult data. Obviously, lack of compliance. I thought a lot of people say they stopped taking the medicine because they felt like they didn't need it anymore, but it was because the medicine was working. That happens. Negative life events, rapid decrease in discontinuation of therapy. 40 to 60% of youth with major depressive disorder have relapsed after successful acute therapy, and that's what indicates the need for continuous treatment. Sometimes kids don't respond as well to medication either when they try it again. Recurrence is emergence of major depressive disorder during the recovery period. Clinical and non-clinical samples, the probability of recurrence is about 20 to 60%. 1 to 2 years after remission, 70% after 5 years. So it's a decent number. Recurrence predictors, earlier age of onset means you're probably more wired that way. Increased number of prior episodes, again, you're kind of wired that way. Severity of initial episode, you can kind of wired that way. Psychosis, they said in Harry Potter, hearing voices is never a good thing, even for a wizard. Yeah, okay. Psychosocial stressors, again, you're just having a lot of things on your plate. Dysthymia and other comorbidity, lack of compliance with therapy. Bipolar disorder, 20 to 40% of kids with major depressive disorder develop bipolar disorder in 5 years of onset of major depressive disorder. Predictors of bipolar disorder, with the early onset of major depression, psychomotor retardation, psychosis, family history of psychotic depression, family loading for other mood disorders, and pharmacologically induced hypomania. And that's where you give someone medication and they get hypomanic, like Prozac. It's suggestive, not absolute. That said, though, pretty much the criteria for bipolar disorder is if you get hospitalized because of a manic episode, it basically makes you a bipolar disorder. What else? Risk for depression increases 2 to 4 times after puberty, especially in females. Genetic and environmental factors are things like non-shared intrafamiliar and extrafamiliar environmental experiences, basically how parents treat each child. Where's the, I kind of want to get to the meds. Genetic factors, again, genetics do play a role. Children with depressed parents are 3 times likely to have a lifetime episode of major depressive disorder. Prevalence in major depressive first degree relative is 30 to 50%. So again, it's fairly common genetically. That's why it's also nice to ask about, you know, what the parent's taking and if it's helpful for them. Sometimes that can be helpful with choice of medication. GeneSight is not recommended by ACAP. You all familiar with GeneSight testing? GeneSight testing is where you get this fancy, expensive test to find out what antidepressant is best for you. All it's doing is checking your liver function. That's it. It has nothing to do with neurotransmitters. So basically, all it's doing is finding out what you're going to filter out faster. But that, again, it just means you probably just go up on the dose is all. So that's why it's more important to ask about what the family's taking before. Clinical course, other factors, again, poor school success, low parental satisfaction with the child. You know, and when I see that a lot at the jail, just unfair pregnancy, the parent who's not involved, that kind of thing. Or if the parents are depressed themselves. Learning problems, again, poor school success, other psychiatric disorders that interfere with the child's learning, personality traits of being judgmental, angry, having low self-esteem, dependency, cognitive style and temperament, negative attribution styles. You know, I hate to say it, but I mean, my daughter is like, she thinks she's better than she really is at everything, which is kind of nice, you know, you kind of bring her down. But my son, like, you know, he was at batting practice the other day and he missed some balls. He thought he did terrible. He beat himself up. So he kind of has like and it's probably because, you know, his sister's so overbearing. But anyway, temperament is important. Just so, you know, there's a vulnerable temperament too. A vulnerable temperament's, you know, the kids that probably see with a lot of conversion, a lot of like, you know, I'm more likely to have somatic complaint because of something going on. Whereas I usually see it more trauma. Trauma really matters a lot. So if you have a really resilient temperament, you're probably going to do okay with some kind of trauma. But if you have a kind of poor baseline temperament, for vulnerable temperament, you're more likely to have problems after trauma. Again, you know, recent adverse events, conflictual family relations, neglect, abuse, biological factors just enable inability to regulate emotions or distress. I'm going to go a little bit faster because I want to get to the meds. So treatment research is kind of sparse in children because it's hard to do research. It very depends about whether psychotherapy or pharmacotherapy or combined should be first line. That's what we're going to talk about the TADS trial. Initial acute treatment depends on the severity of major depressive disorders, number of prior episodes, chronicity, age, contextual issues, and family. Another thing I see a lot of that, you know, the family educational level. I feel like there's still like, you know, some magical thinking when it comes to like medicine or something like that in the area. Okay, so depression is in youth is a serious illness associated with significant morbidity. Like I said, most teenagers age 15 and 19 is the number one and number 2 cause of death in this age group. In short-term clinical studies, antidepressants in youth show that there's a 4 versus 2% medication to placebo risk for suicidality. So 4% for medication, 2% for placebo suicidality. The problem with that is, you know, suicidality is a risk factor for depression, period. Observation data supports introduction of SSRIs associated with decreasing completed suicide rates. Only fluoxetine, escitalopram are FDA approved for depression. Did y'all know that? No, those are the only 2. After consent, discussion with parents together, provider and parents can consider the use of antidepressants in youth. And remember, 16 is kind of the magical number there.
So with regards to fluoxetine and escitalopram being the only ones that are FDA approved, is there like a push in the psychiatric community at all to like expand that with more research, or is that just kind of like, do you think it's going to be this way for a while?
So the way research works is it costs a lot of money.
Right.
So there's not like Remeron. We use Remeron all the time, but it's generic. And there's just no money to get a new FDA approval for Remeron in this age group. That said, and I'll show you a little bit, I'll get into it. Zoloft, which is amazing antidepressant in adults, 69% efficacious in the trials for it to become FDA approved in kids, which is better than Prozac's efficacy. But the placebo had a whopping 59% efficacy in the clinical trials. So that's why that did not get approved. So that's the thing. Getting professional help has an incredible rate of placebo effect in children. You know, they're kind of suggestible anyway, to some extent. So that's some of what's going on there. So that's why I mentioned a lot of other ones that are actually FDA approved in this age group, just not necessarily for depression, kind of give you more options. What else? Psychotherapy is fine for mild to moderate major depressive disorders. CBT, cognitive behavioral therapy, and interpersonal therapy, probably kind of working with your peers and working with your parents, family therapy. Antidepressants can be used for, again, not bipolar disorder, or it can be used for non-rapid cycling bipolar disorder, which really don't have too much. Psychotic depression, sometimes you just need an adjunct, like an atypical with it. Sometimes due to the psychosocial context, pharmacotherapy alone may not be effective, again, like probably on DSS and stuff like that. SSRIs can induce mania, hypomania, and behavioral activations as being impulsive, silly, agitated, daring, related to 5-HT2C, but sometimes it's just when they're all around. So like if you're depressed and mopey, or you're anxious, sometimes you're going, again, from here, where, this is my baseline, to here. Parents may perceive it as being overly activated, but really they're kind of just back to where they probably should be. So you just want to find out if they're doing anything weird or strange or inappropriate, things like that. Small number of case reports, again, between the SSRIs treatment and increased risk of suicidal tendencies. And we'll talk about that a little bit. They think it may be related to behavior activation, akathisia. A lot of it can be related to just the way the dosing was, like Effexor and Luvox were the big ones. And their immediate release versions kind of just have like up and down serotonin levels throughout the day. And it's kind of really just throwing kids off. Now they have longer acting medications that are consistent throughout the day. It didn't cause as much trouble. But the two main ones that got dinged for the black box warning were Effexor and Paxil. It was Paxil and Effexor. Those are the two big ones that got implicated. And that's why they just did a blanket statement for anything ever given for depression. Even Abilify, which is an antipsychotic, works so different, but because it has indication of depression, it got a black box warning. It was mostly Paxil and Effexor. And again, it was because they were such short-acting medications. There was just an inconsistent level of serotonin throughout the dosing of it. They just didn't dose it right. They probably should have been dosing it 3 to 4 times a day, and they're just dosing it twice a day. That's really what was going on with that. SSRIs do act on the cytochrome P450 system 2D6 fairly potently, so that kind of plays a role. SSRIs interact with other serotonergic medications. You can get serotonin syndrome, which is agitation, confusion, hyperthermia. I've only seen this in overdoses in the PICU typically, but medications you need to watch out for that are things like stimulants actually work on the MOI system, obviously MOI, obviously other SSRIs, SNRIs. I think there are a couple of tramadol. There are other medications that we give that can cause serotonin syndrome. TCAs, I think the main things to know about TCAs is they're kind of the grandfather to the SSRIs. They tend to be used mostly for pain, sleep, things like that. They do work. The problem with the TCAs is that an overdose is a significant risk for suicide with tachydysarrhythmias, bradycardia, with or without heart block, and that's related to like the anticholinergic effects. 1 week's worth of it, overdosing on TCAs is enough to kill you. So that's why we don't use TCAs very much anymore. I've seen so many kids overdose on SSRIs, just, you might have some, clonus, large people, and that's about it. Okay. So this is the what I was talking about, the fluoxetine data. Fluoxetine got approved for depression in this age group because it separated from placebo. It was 58% effective, whereas placebo was 32%. That's still pretty high placebo right now. Paxil, again, we don't really use that one too much, but it was effective in that clinical trial, 62% compared to the TCA at 50%, where placebo had 46%. Fluoxetine, another study where it separated from placebo, 41%, 20%. And then this is the sertraline study where they tried to get it FDA approved for depression, 69%, it's really good. And placebo's 59% was better than Prozac's, the one that got, so there just wasn't the money for it. So according to the American Academy of Childhood and Psychiatry, they recommend Prozac be the first line medication indicated age 8 to 18 for depression, 7 to 18 for depression. What that matters there is that it's been tested safe in this age group. Really age 7 and up. There's a liquid form. It's not 1-to-1 though, so just be careful about that. It's a potent inhibitor at cytochrome P450 2D6. It's nice, it has a 36-hour half-life, so compliance is not a big deal. You know, if you're taking it like 5 or 6 times a week, you're doing pretty good. So there's also a little withdrawal. So if you do miss, you're not like gonna have side effects. There's a black box warning for suicidality, and it does hit 5-HT2C, which is nice because that hits norepinephrine, dopamine that helps the mopey kids who have fatigue problems, anhedonia, concentration, and attention. But getting that extra little norepinephrine kick right there can make a couple kids a little bit more anxious. That's where that activation comes from. Prozac is nice. My wife told me I could take. She got some postpartum depression after, well, obviously after kicking. And you know, she's a doctor, and I think I'll know that. You know, I think she admits that she was kind of stubborn. I'm a doctor, I don't need help, but it's really important to get help. She loves Prozac. She's a big advocate for Prozac now. So I also, you know, like recommend things that spot people not going to do. My brother takes Zoloft too for his anxiety. He seems to like that pretty well too. Lexapro is kind of one of the newer ones. They tested it down to age 10. It didn't separate from placebo. It did separate from placebo at age 12. So again, as far as evidence-based medicine, I hope they wouldn't do this to you, but on my boards, there was a 10-year-old with depression, and they gave you a list of Zoloft, Lexapro, Prozac, and Paxil. Which of these medications would be best? Isn't that mean? That's hateful. And that's the only reason why they did that. So hopefully they will not do that to you, but they may. They may do that. So yeah, so Lexapro is only indicated age 12. You know, it was tested safe down to age 10. There's the S enantiomer of citalopram. Remember your organic chemistry. Right now it's the only reason I ever had to take that. Okay. So there's less antihistamic properties, so less QTC prolongation. Citalopram used to be indicated at up to 80 milligrams. Now it's only 40 milligrams because cardiac effects due to anticholinergic. That's why. It's a mild inhibitor of cytochrome P450, so that's why it's a good choice for polypharmacy. Zoloft is indicated age 6 and up for OCD. So again, tested safe, and we know it's effective. It just doesn't necessarily separate from placebo. There's liquid. It does work on cytochrome P450. You should know that the average dosing for Zoloft for anxiety in the CAMS trial, the childhood anxiety multimodal study, was 134 to 147 milligrams. So you tend to have to crank Zoloft up. I would guess the depression range would be more like the 75 milligram range, but still, that's something to know because a lot of times people stop at like 25 or 50 of Zoloft and think it doesn't work, but you usually have to crank the Zoloft up a good bit. Again, black box warning for suicidality. We talked about Celexis, citalopram, and it does prolong QTC. Fluvoxamine is indicated age 8 and up for OCD. This is one that's tricky because it's 3A4 and 2C19. So if there's a board's question about that, they might show like something that it also works at 2D. So like say you have side effects to Risperdal, which is 2D6, or Haldol, which is 2D6. They'll go, which is the one least likely to cause it? And it would be Luvox because it doesn't hit 2D6, it's 3A4 and 2C19. That was on my boards too. Really neat. What Cymbalta just got an indication recently for generalized anxiety disorder, age 7 to 17. Remember, this is SNRI. This is the one that's kind of taking the place of TCAs for pain and depression. So that's one, this one's kind of nice. Usually the pain dose is kind of like the 90 to 120 milligram range. Usually have to crank it up a little bit for that too. Other medications that are not FDA approved, again, venlafaxine, that's the one that got deemed really hard for the black box warning. Atypical antipsychotics, again, Abilify has adjunct indication. Trazodone is actually indicated, the way it's supposed to be dosed is 25 milligrams or 50 milligrams 3 times a day, but we use it for sleep a lot. It's good for behavior. Bupropion, we don't really use, or mirtazapine. We use a lot of Remeron because it's good if you have appetite issues, sleep issues, and it's the fastest working, I think we talked about. It's used pretty often, so you're not deviating the standard of practice too much. We talked about dereliction of duty, deviating standard of practice. It's one of the 4 Ds of a lawsuit. Remember, it says damages directly related, or duty damages directly related to deviating the standard of practice. There's like deviating dereliction, kind of different. But it's mirtazapine's used enough where we probably wouldn't get deemed too bad by using that. Bupropion, sometimes people use Wellbutrin. That happens sometimes, just watch out for seizures and things like that. Seems like a lot of kids overdose on that one and get seizures. What else? Again, they recommend a minimum 1 to 2 office visits every 4 weeks during the initial months of antidepressant. And the FDA recommends visits during the first month of treatment bi-weekly, 2nd and 3rd months. TADS trial. TADS trial is the gold standard for depression, age 12 to 17-year-olds with major depressive disorder. They wanted to compare the efficacy of fluoxetine. So that's why I always go with that one first, because this is the major evidence-based study. A fluoxetine CBT combination of fluoxetine and CBT versus placebo, which is really mean to leave somebody on placebo too long. So they didn't do that. They switched them over to an active group. Basically, what they found out was at 12 weeks, combination of fluoxetine and CBT was 71% effective, pretty good. Fluoxetine alone was 61% effective, and CBT alone 43% effective. Again, kids, it really depends on your cognitive level and how old you are for CBT to kind of work. So it's a bit more variable. But that's pretty effective, 71% at 12 weeks. 18 weeks, Prozac and CBT, 85% effective. And then fluoxetine alone about 69. So again, pretty effective. And then everything's about 80% by 36 weeks. So again, when you're trying to sell the treatment plan, usually I talk about TADS trial. If you want to be aggressive, get this depression better, we can use medication and therapy combined. No suicidal thinking suicidal thinking decreased substantially in all treatment groups. So actually treating the depression made the suicidal thinking go down, which is important, especially when talking about the black box warning. There were higher rates of new and alarming suicidal thinking compared to the CBT part, but there were no completions, and the presence of suicidal ideations was about 30% based on. The Tordia trial was the treatment-resistant study. And basically, what they found out is if you've got somebody on a medicine at the right dose for long enough and it's not working, just switching to anything else should work. Is what they found out in that trial. They compared fluoxetine, Paxil, Effexor, either alone or in combination. They wound up getting rid of the Paxil halfway through the study because of the black box warning. Paxil was one of the ones implicated with it. And it was basically just trying to find out what would be the best thing to do. So again, it was like switch to another SSRI, switch to venlafaxine, basically switching them around. The thing about Effexor is it increases your diastolic blood pressure. If you ever get a question on that, that was on my boards, is that Effexor can increase your diastolic blood pressure. Really kind of odd. But again, because of concerns of safety and efficacy, the Paxil was replaced by citalopram during that study. And again, the efficacy was about the same for all the medications during that study. Adding CBT did help all of them as well. And I've only got about 35 more slides. Most of it's like related to this is related to black box warning and stuff like that. So basically just remember that it's complex, and sometimes it's kind of difficult to tease out. Don't always think a kid's a bad kid because he's not listening, he has anger issues. Sometimes you can kind of tailor the medication for the kid. Again, if they're more anxious and depressed, maybe Zoloft would be better. If they're a little bit more mopey, then a Prozac would be better. Again, always consider substance abuse, ADHD issues, sleep hygiene. Sleep hygiene is huge. CDI is a scale that you can use for depression. I use that when we do consults a good bit. I don't know if y'all use something specific in your clinic or not. What else? Yeah, there's all kinds of like different level scales. I just add that there for y'all.
Isn't the PHQ-9?
Yeah, the PHQ-9
That's like
has.
18 and above.
Yeah, there's a variation of the PHQ-9. It's like this. Actually looked up, then you're gonna ask me that before you came in. It's called the Severity Measure for Depression Child, age 11 to 17. Severity Measure for Depression Child. Is what it's called. And it's, I don't have a problem with the PHQ-9. They're just gonna leave off the irritability part. And then a lot of times the kids are have more mixed symptoms and then the shorter periods.
I'm pretty sure it's from.
Yeah, we like the PHQ-9 in our office too. That's fun. So yeah, the board's question, whether pre-medication treatment in children or not, this SSRI would be indicated for an 8-year-old boy named Zach who has major depressive disorder. All right, I did good. I got an A. You did good.
What is
My name is so here's all the FDA stuff if you want it, or like the black box warning stuff too. So I can send this. I told you I could send this to her. If y'all want to take a look at it, but basically, actually these medications are protective age 24 and up for depression. So. Cool. Thank you. Y'all have any questions or anything like that?
So would your go-to for starting or like treating depression, that would be the fluoxetine based on that stuff?
Yeah, depending on the age. If 12 is like my magic number, if they're under 12, sometimes I'll start at 10 per week. And then go up. You're more likely to have like headaches and stomach upset.
So what was the max dose that, or the level that you might need to crank up the Zoloft to? Yes.
The average dose for sertraline for anxiety was 134 milligrams with cognitive behavioral therapy and 147 milligrams without cognitive behavioral therapy. For anxiety, you don't always need like those high doses for depression. So it kind of goes like this: depression, probably like a third or half the way up to the max. Anxiety, about half to midway up, like 75%. And then for OCD, you tend to need like the 75% to 100% dosing. For OCD, OCD usually needs a little bit higher dose than depression and anxiety. There's a Stanford study where they went up to 400 milligrams of sertraline, and it was just as effective. It was more effective and just as well tolerated. And the max dose typically of sertraline is 200. That was an adult study. For the age, also good study.
For the black box warning, with the increased suicidality, with antidepressants, I've always been taught that part of that number, at 2 to 4%, was people actually getting the motivation to perform the exercise.
I heard that too. So yeah, what it is, you already have those thoughts of hurting yourself. You're so mopey, you don't have the will to act on it. I think that can have something to do with it. And we saw that chart where, again, you have all these receptors saying, give me serotonin. Once it sees it's on the way, you downregulate, and then you still feel bad, but you actually haven't had that response rate. So that's kind of like the same thing you're talking about. Yeah, all that kind of plays a role. So that's why that first month is really important. And again, letting them know about letting the family know. The nice thing is we typically have people that are supervising the kids, so it's kind of nice that we have folks that can watch over them. And there's also magical. I want magically better the next day, but that's that way.
You're saying the Prozac is helpful for behavioral issues?
Yeah, I like Prozac a lot at the jail. And if you think about what would you give your kid? Would you rather give your kid atypical for their behavior and their anger outbursts, or would you rather give them like a SSRI? Yeah, I mean, that's important for y'all too, I guess. I always think, like, when I'm thinking about prescribing medications, I always think what I would give my kid first. You know?
I have one more question. So is there, well, is there like a secret or a formula that you would use to try and prevent and improve resiliency to have like the best time event to hopefully reduce any likelihood of having depression like later on? Like, is there something?
So cognitive behavior therapy buys you a lower dose of medication and it buys you probably less time that you need it because you work on your coping skills. You know, that's really kind of nice.
Is there anything that you would do beforehand, like to kind of prevent depression and not prevent?
So cognitive behavioral therapy, so there's the cognitive part where you reframe your maladaptive thoughts, but the behavioral part is basically doing the fun stuff. Like getting there, like sitting there on TikTok 10 hours a day, you know, that's the behavioral therapy part. Getting outside and playing or getting outside and doing something like social media. If you do an hour of social media, you're doing an hour of like a kid building Legos. What do you have to show for it in an hour? You know, like, mommy, look what I did, versus like, mommy, I was on social media with all these mean, angry people. You know, so yeah, that's the behavioral part of cognitive behavioral therapy, is doing enjoyable activities, something you feel good about yourself. You know, spend your time with meaningful time, having some meaning. I think right now a lot of people have problems. They just don't feel lost and don't seem to have that much meaning, and it's causing problems. You have to have meaning in your life. That's what I really like. Sports. I really like, you know, activities. But it has to be in moderation too. You know, like if you take sports too seriously, then it's not fun anymore. If you take dance too seriously, it's not fun anymore. If you take cheer too seriously, it's not fun anymore. So moderation. It should be fun. Kids need fun. Y'all need fun.
Okay. And when we refer our kids to Columbia Mental Health and things like those resources that we have in our clinic, that's primarily what they're going to be getting.
Yeah, well,
once they're involved.
If they go to Columbia Mental Health, they're going to get a case manager. They should be getting like therapy and medication. They should be assigned a therapist, like they're required to. They have to sign off on the therapist that they have a plan. Unless I, as a psychiatrist, say they don't need therapy, then I can just have to do bed management only. But once they get in there, they're automatically therapy and medication. Family therapy is really important for a lot of the angry kids that have like ODD.
Yeah.
Because a lot of this, like, you know, we had a case the other day with autism, like yelling at the kid to calm down and stop doing that doesn't seem to help. It tends to make the kid angrier. So working on, you know, how you discipline your children, things like that can be helpful. It's really important just for parents to spend time with their kids too. The kid's going to listen to you if you spend time with them. And they, you know, that's the banking theory behavior. You know, if you want your kid to do something, you have to have, it's like taking a withdrawal out of the bank. And the only way you put money in the bank is by spending quality time with your child. The kid's not going to want to listen to you, or you can't make a withdrawal if you don't have money in the bank. You know, y'all have my cell phone number if you want to text me, like questions down the road. You got somebody in a clinic, like, oh, we'd be here. So, was it Rylan? Blair texted me like last, like 6 months ago.
Really.
Yeah, she's got practice for a while, so yeah, y'all can do that too. So that's what I'm here for. Anything else for them?
Thank you.
Thank you.
Yeah, thank y'all.
So Scott wants to know, taper off to SSRI.
Prozac, no.
For Prozac?
Yeah.
For any SSRI?
Prozac, you don't have to. Zoloft, I would probably just be like. So Stahl said you can take quantity off in 3 days. So really, if you just kind of do like a half dose for like a day or two, and then you could do a quarter dose. You can do it.
Oh, really?
That's really quick.
Yeah, just be careful that you don't want to follow, make sure they're not having problems. As far as like the.
It takes like 2-3 weeks for it to build up.
Usually I like to.
I said, it blows my mind that it takes like 2-3 weeks to build up in your system and get to a good maintenance level, and then it's like 3-4 days to taper off to.
Yeah, some stuff is still faster. That's why,
Right.
like the immediate releases, like the Effexor and the Paxil, that's why they had so much problems, because it's just a steep flow. I like to do it every visit. Like I'll just do like a half dose.
Okay. So that ends up being like half dose every couple of months.
Yeah. and that's
Like, oh,
it's usually like you're not,
Yeah.
like it's different season.
But it's just, it's can't even,
Makes sense.
I know.
There's
I
no
know.
withdrawal.
No, not. It's like cocaine.